This patient right here, right in front of our eyes, has oral cancer. This is a stage 1 early stage cancer where we have a much better success rate right now. But we're never going to find it if we don't look. Before you do a cleaning, take the device out, put the glasses on, and you're going to see a lot more bacteria. You're going to see plaque. You're going to see Candida albicans at times. If patients have some sort of yeast infection, which is Candida albicans, we're going to see these things. And then all these other lesions are going to appear dark, whether it's geographic tongue, erosive lichen planus, irritation fibromas. They're all abnormal lesions. They're all going to appear dark in color. And the reason why we stress the word abnormal, because it's not just cancer that's going to fluoresce dark. It's anything abnormal. So again, this is where we stress the 2-week follow-up protocol. Because if there's an irritation fibroma or an aphthous ulcer that's there today, and it's still there in 2 weeks, maybe it's not an aphthous ulcer. So the 2-week follow-up protocol is essential, because we know that any traumatic lesion, any of these little lesions that we see here, if they're non-cancerous or not precancerous, they're going to be gone in 7 to 10 days. And it's a good way for us to snap a picture with your phone, with your intraoral camera, with your smart filter. And you have a point of reference now. When that patient comes back in 2 weeks, we now know what we're looking for. But now with this type of technology, it's going to look completely different. We're going to have some blood vessels, and these different things are going to be highlighted. So again, normal, healthy tissue, a nice green-yellow fluorescence. And we can see the different spots of the mouth here. There's also some small, subtle changes that we may pick up on at times. The papillae on the tongue. As you can see right here, there's little dark spots all around the tongue. But we also see with the white light, it's just more pronounced now. Attached gingiva is always going to be uniform and dark all throughout the tissue. And you can see here, it's nice and uniform and dark. The tonsillar pillars are going to be dark back there. But if you see this right here on the right side, and then you see it again on the left, then it's something with the anatomy. And again, you're going to see this pretty consistently. Pigmented lesions. We have to understand this technology and the fact that if it's dark under the white light, it's also going to be dark under this technology. And you can see a patient with extra melanin in the pigment, an amalgam tattoo. All these things are going to be darker if they're darker under the white light. We have to understand that. That's why the white light exam is really essential to be the first part of the protocol. Hyperkeratotic lesions occur when there's an extra epithelial layer, an extra keratotic lesions that are there. They're going to fluoresce a hyper white color. This occurs a lot of times in tobacco users, or if there's some lichen planus area or leukoplakia lesions that are hyper white lesions. So these are lesions that are going to be highlighted. Again, these keratin, extra keratin tissues aren't the ones we're looking for. We're looking for these dark lesions, but these still raise an interest when we're looking at the different lesions throughout the mouth. Again, nice, normal, healthy fluorescence. We're going to see this most of the time. This is an abnormal lesion. It's dark. Now again, remember, dark doesn't mean cancer. Dark means abnormal. But here's what we're going to do. We're going to have you back in 2 weeks. We're going to reevaluate this lesion. If it's what we think it is, it should be gone in 2 weeks. But if not, we're going to take that next step next time we see you. So why don't we have you back in 2 weeks? So the patient gets a biopsy and this lesion comes back to be carcinoma in situ. This is an early stage cancer where right now this patient has an 80 to 90% success rate. That's the great news. Yes, they're infected. Yes, they have cancer. But right now, we're going to be able to cut this lesion out. And this patient's going to have a greater success because we found it early. Again, left side you don't really see too much, but now you see a pretty distinct dark spot. This is squamous papilloma. This lesion right here is not cancer. So that's really our goal, again, to find these things that are abnormal, whether it's cancer, HPV, dysplastic tissue, fungal infections, all these other things that we need to learn about earlier stages. That's what we're trying to do here. This white light exam is the #1 part of the exam, and then we're going to go ahead and do the OralID examination next. This is a precancerous lesion right now, where if we cut this out, this patient has a 90% and above success rate for long-term survival here. This is a carcinoma in situ, early stage cancer. Here's one that we show a lot because this is an invasive cancer. You can feel it, you can touch it, it's rough when you palpate it, it looks bad. But you can see there's fungal infections all over this. This is an invasive squamous cell carcinoma that's glowing from the orange bacteria that's helping this cancer grow. This kind of just shows you a way some of the orange bacteria grows sometimes. Again, 2-week follow-up, see what's going on with the patient. This is a squamous cell carcinoma. This is a lesion that right now we can address much earlier. This is an early stage, low-grade carcinoma where we have a much better prognosis long term. This is one of the recent lesions that we found. Again, the HPV lesions are being more and more prominent. And this is one that we found at a clinic we work with here in Houston. This patient probably should be seen every 6 months or more frequently than our normal visits, because any prevalence of HPV in our body is going to increase our risk for oral HPV, and more specifically oral cancer. Classic case, seen this a million times. But now with this technology, we see it's a little darker. It's not consistent with candidiasis, but it still raises a red flag and says, you know what, something's going on here. So a small, subtle change like this on the right side turned out to be moderate dysplasia, and we don't really see too much on the left side. And that's really what we're looking for here. This is an invasive squamous cell carcinoma. And again, we're going to do our differential diagnosis, look at the right side versus the left, and of course, this is going to be pretty dark. And again, do your differential diagnosis. Look how simple this is. Look at the right side. It's extremely dark. It's pitch black. The left side looks normal.